Hello, everyone, to the last episode of MedTalks before the big summer break. I'm happy to have Miriam Santos Freire here today, and we are going to talk about sickle cell disease and also about her experience as a medical translator and linguist in this field. But first of all, I would like you, Miriam, to introduce yourself and tell us a bit about your background.
Hello, it's really nice to be here. I hope you can hear me well. Oh, hi, Karen, and another colleague from the linguistic validation. And so, who am I? So, I was born in Angola. I am Portuguese and British by now as well. I lived most of my life in Portugal. Angola at the time was an, how do you say, former colony, not politically correct, but it was a former colony before it became independent of Portugal. And so Portuguese, and then about 10 years ago, I relocated to the UK, and I have been living in Cambridge for the past few years. And I am a patient with living with sickle cell disease. That's why the topic today is sickle cell disease as well. But I've been a translator all my life. I trained academically as a translator, mainly in localization and IT, and then fintech, and then subtitling with AI-generated processes, and more recently, medical translation and linguistic validation, coming from quite a few years as a patient first, and then as a patient advocate for the past, I don't know, over 10 years. So I started doing a lot of medical translation as a volunteer and patient-facing communication, leaflets, contributing with review, proofreading, and a lot of different things. And so when AI started interfering with the IT localization and so on, as I became more and more involved with patient advocacy, I started learning on clinical trials and research. And so it was just natural to know more about medical translation and then linguistic validation, which is very appealing from the, let's call it human side, and really culturally adapting and focusing on the patient. That's what I'm about. So I think that's a good thing. Yeah.
Well, thank you for the overview of yourself. I always like to start at the very beginning. When you grew up, were you a healthy child back then? How did you, or when did the sickle cell first appear in your life? And also, maybe you would like to explain us and our listeners what sickle cell actually means, what it actually is, because
Okay.
it counts as a rare disease, doesn't it?
It is a rare disease. It's not a rare disease in all of the countries. For example, I don't suppose it's a rare disease in the US, but in many parts of the world, it is a rare disease. And in Europe, it is a rare disease. And it's a blood condition. And you're born with it. So it's a genetic condition. And it's a group of inherited blood disorders, which means that it is passed on through genes from parents to their children. And it is a lifelong condition that affects how the body produces red blood cells. Normally, the red blood cells are round, flexible, and rich in hemoglobin, which allows them to carry oxygen throughout the body. In people with sickle cell disease, the red blood cells can become hard, sticky, and shaped like a crescent moon or sickle. That's where the name comes from. These sickle cells do not move through blood vessels easily. They can block blood flow, reducing oxygen delivery to tissues and organs. And this can cause severe pain, which is like the top symptom, let's say, anemia, organ damage, and a range of long-term complications. I was born with sickle cell, as I've
As you said, yes.
as everyone is. And I was only diagnosed when I was about 3 years old. So I lived in Angola at the time. I would come to Lisbon every now and then with my family. And after a flight, there was a very painful crisis. And the pediatrician that assisted me at the time He was known to the family, and he said, I suspect that it is something a little bit unusual, and so let's test the whole family. And we tested the family, and so that's it. Then my blood was sent to several places for a diagnosis confirmation, and that's it. That's when, so I only knew that I had sickle cell, and there was very little knowledge at the time, either in Portugal or in Angola, where I live at the time. And when I was 3. Nowadays, and nowadays means that in the last 5 years in Portugal, it's part of the newborn screening plan. So it means that it's one of the diseases that is diagnosed with a Hill-Prick test, which is really good. And in the UK, it has been like that since the 80s, probably, but it's not universal everywhere, even in Europe. In some places, it's only regional. In some places, it's only targeted to the families that you know that have sickle cell. And in a few countries, it is indeed with newborn. So just saying a little bit more about sickle cell disease affects millions of people worldwide, particularly those with African, Caribbean, Middle Eastern, Asian, and Eastern Mediterranean ancestry. It is one of the most under-resourced inherited conditions globally, despite its significant impact on individuals, families, and healthcare systems. I have homozygous, so HbSS, which is often referred to sickle cell anemia, and is generally considered the most severe form of the condition. People who inherit only one alter gene have sickle cell traits. They are usually healthy carriers, although this is very debatable, but can pass the gene on to their children. The good news is that outcomes have improved enormously over the last few decades. And while there is no cure, newborn screening, preventative care, vaccinations, antibiotics, blood transfusions, and newer treatments, such as stem cell transplantation and gene therapy, are helping people live longer and healthier lives. However, it still requires lifelong management and remains a very serious condition.
All right, that was a lot of information in not a lot of time. Great. Now, I would like to ask a bit more into, so you were 3 years old when you had a painful crisis, you said, after a flight. Is that right?
Yeah.
Yes. What sort of pain? I mean, when I think back, or let me start earlier. When I think back when my kids were very little, they cried a lot and nobody knew what it was, like what was the cause for it. Luckily, they are not sick, but they were just overstressed or whatever. But I guess you had those kind of pain already before you were diagnosed with it. So how did your parents experience your very young childhood? Do you remember? Did you talk about it ever?
I know that there is a pack of symptoms that usually allows doctors to think about sickle cell, which is usually in children. The hands and the feet go puffy, so they swell quite a lot. One of the common traits, and I had it through all of my childhood, is jaundice, because it has to do with the sickling process. Dehydration is also part of it, and the pain comes from the red blood cells with a spiky form, that usually the blood gets thicker with less oxygen and less hydration, and so it's like they clog in the joints. So the pain is really usually associated with its very strong aching pains in the knees or the elbows or the everything that is makes a corner.
So joints, so
Yeah.
basically joint pain.
Yeah. And
Yeah.
it is really, really intensive, but it's never exactly the same. It changes a little bit, but it's like excruciating pain. And depending on the crisis, it can be stronger or lighter, but it is really, really strong.
And when you say the blood clots, do you then also suffer from strokes and heart attacks, embolias, and all this more often?
In children, strokes is very common. and there are specific tests that are done to kind of not prevent, but to see if there are any signs for it. But it's very common in children. I didn't have it, but I had, for example, pulmonary embolism in 2022, unannounced, which I think it's not that common. And it was really weird because I just felt so tired with no apparent explanation. And it was right after COVID where I didn't move as much as it's advised to, but I was part of the shielding community and a lot of stuff. So it was really weird. And that's what I mean when it's very unpredictable. It's invisible because you get to have, there are certain traits that we can look at someone that has sickle cell and say, well, it matches, but usually not that much. And you can look absolutely normal, be completely normal in your day-to-day, and all of a sudden, because there is some infection or because the temperature changes a lot, or there are a number, dehydration, you overexert yourself, there are a number of conditions or situations that all of a sudden, bang, you have a painful crisis. And then they need to go to hospital, and hospital means maybe antibiotics as a prophylaxis, but usually IV fluids, rest, painkillers, and they can be really strong. It can go up to morphine because the pain can be comparable to like a woman giving childbirth. It can be really strong, and most of the times it is really strong.
Yeah. Oh, wow. That sounds really intense. Do you then also get blood thinners because you want the emboli to?
I am on it.
Yeah.
I think it comes with aging, so it's not like everyone has blood thinners. It is depending on the organ damage or what you go through. Then yes, right, for the past maybe, I don't know, 4 years now, I'm on blood thinners. I remember that there were periods of time in the past that I took, for example, the small aspirin for specific periods of time. And I think it works as a blood thinner, but it's not a blood thinner specifically. And now it's different. I really need to take it. Yeah.
Yeah, aspirin is like a pre-blood thinner thing.
Yeah, there you go.
Yeah, yeah. I'm asking because I thought if you say that kids, it's very common in children that they have strokes, then I would think that they would be on blood thinners to prevent those strokes. But then on the other hand, being a kid on blood thinners, I imagine that being so difficult.
Yeah.
Yeah, but it is. Do you know if they do get blood thinners?
Or maybe I don't have that experience because so I'm 57 now. When I was born and during my childhood and even teenage years, there was little knowledge about sickle cell. It's one thing that really advanced over time, and it was better for a period of time because it was integrated in the medical courses and even I think that the nursing as well, because I noticed from my nephews and nieces, some of them went into healthcare related paths and they knew about it in school, which was really interesting. So I know that there is more knowledge about it, but then because it's on the non-malignant side of hematology, it has been removed again. So it's like in an optional curriculum that you can learn about it. Or if you get really into hematology, probably you know more about it. So people hear about it, but they don't really have any specific training in the general training, let's see. And then once you start narrowing down and focusing on hematology, then you learn more about it. Yeah. The malignant conditions take most of the scenario in hematology.
Yeah, it's crying more for attention. Yeah. So you were 3. You were diagnosed with sickle cell.
Mm-hmm.
How did your journey go further? Like, what happened from then on? You had the diagnosis. Did you immediately get any medication, any treatment, or what? How can we imagine your further childhood?
Well, there wasn't a lot. There was a concern about infections because you really need to be aware of infections and try to prevent as much as possible. for a long period of time, I took penicillin as a prophylactic
Oh, wow.
measure. Yeah, it was like every month I would have to take it, just to prevent a lot of the infections. And I think that along with a lot of hydration and a balanced diet, some exercise, but not a lot of exercise, because you can't really get tired, because it's one of the things that will trigger. And fatigue is a constant, because your hemoglobin levels are much lower than normal. For example, my normal hemoglobin is 8.5, which is not that much, when a woman hemoglobin is between 12 and 14, as far as I know. So it's quite lower. and that contributes to a general sense of fatigue, and just
Yeah.
learn to live with it. So that was one of the things. So overprotected, not to a lot of having a lot of concern with the changing temperatures. For example, I didn't do PE in school during autumn and winter when it was colder. I had to be really careful about the changing rooms and the drafts, and
Wow.
a lot of different things. And my mother was very present at school, which didn't make me a very popular child. Because I came, so at some point, let me just go back a little bit. At When I was about 5, so we lived in Angola. It's started to get politically unstable before the independence, and because my health wasn't really good, and we had family in Portugal and everything, the doctors really advised to move to a temperate, a milder, more controlled country. And so it would be southern France or Portugal. So the whole family moved to Portugal. And with that came adjusting to a different, colder weather than it was in Angola. So in Angola, the problem was heat and humidity a lot. In Portugal, the winters were rougher, and so we had to take that into consideration. So it wasn't easy peasy. Didn't know a lot about it. I was a very curious child. I was always very brainy. I was always they told my parents that my life expectancy would be around 5 to 6. I'm the fourth
Oh,
child. Yeah. And,
wow.
and for example, in Africa, where sickle cell is very predominant, if you don't have the right care structure, it can help as well, because it is a life-threatening. If you don't have enough hydration, if you don't have enough oxygen, if you have very painful crises, if you have a stroke, if you have a number of different things,
Yeah.
it can be the end of it. So, but it was a different scenario. We were in Portugal, care was different. And so fortunately it was okay, and we managed to find a way. Very conditioned, if you can say. Some people ask me, are you defined by sickle cell? I don't think I am defined by sickle cell, but I was definitely shaped by sickle cell. So
Yeah.
one good thing is that my mother always told me that the concern was not that you can't do things because you are ill a lot of the times, or you have a specific condition. You can do as much as any other person, but you need to be aware of your limitations. And that's what I've always done. And I think that's the golden advice that you can give to a child. It's
Yeah.
not easy. In many occasions, it's not easy, but I think that's exactly what you should look for.
Yeah, absolutely. I understand that. You are not your disease, right? You're still you. You're still Miriam. You're still your
Yeah.
thoughts and your feelings. And um, maybe this journey even toughened you up for the rest of your life. I don't know. If you don't get to,
Yeah, yeah, and
I mean,
it plays with your mental health as well,
yeah,
because, and that's why I say that it shapes you, because
yeah,
you learn to be more protective. You are on energy saving mode most of the times, and it means that that conditions your choices. And it also has to do with being very selective and difficult to gain trust from people. And usually people look at you and they, especially, I think that the teenage years were the most difficult and the beginning
Yeah.
of uni, because it's difficult to socialize. And when you don't do everything else that all the other children do.
Yeah.
And when you behave a little bit different, when your mother is in school many of the times, when you don't go to school trips, and there is a lot of things that help a kid integrate that you don't do. And so that shapes you.
Yeah, I mean,
Um,
teenage years are the worst anyway, even as a healthy kid. But then having a condition on top, I think Angelo knows exactly what you're talking about.
Yeah.
Having such a condition on top is oh God, it must be so hard. Um,
I was listening to Angelo's talk yesterday, and one of the things that I even said, well, bang on, when he was saying that when you go for a trip and you need to prepare, and it's like that. So now that I live in the UK, but my family and my friends are in Portugal, I still have my house in Portugal, and so I go there. I try to go at least twice a year when I can, a bit more. But every time I go, and with the patient advocacy, there are conferences and congresses and events that I go to. And whether it is going to London or it is going across the channel to anywhere else, it starts with, first thing, medication. What you need to have, what you need to carry, if you have enough for the period that you are away, and if you have all your medical documents and everything that you carry with you. So it's not the same as Angelo, because I don't have a pump, but I have my stash of medication, which is quite a lot, and I need to carry it. And some of it's stronger, so things related to codeine and morphine and stuff that you also carry, you need to have a special. It's the mindset starts with that. And then you also take a ton of clothes, because the weather can be anything, cold, hot, rain, and so on. So it's a different thing.
Yeah,
Your brain
I
works in a
get that.
different way.
I get that. I completely get that. It's like having a toddler. You have all those thingies you need to think. I had 3 kids under 6 for a while, and it was just crazy. Traveling with them was crazy, and you have that only for one person plus the rest of your life. So
and that thing about the whole life, that's really exhausting. Because
not just as a period.
Because I compare with some conditions, they may be very serious. I'm not questioning that. Everyone has a difficult road, but one thing is acquiring a condition at a specific period of time, and even having the possibility of remission, of getting cured of it. And another thing is living with it your whole life.
Yeah, definitely. Well, I would like to go back. We had the difficult teenage years. Now then, you are in university. What did you study?
Translation.
Was it in the beginning? You nearly, wow, that's cool.
No, I was always drawn to languages, and we did some. It wasn't that difficult. In Portugal, everything is in their original version with subtitles, and I think that helps a lot with growing familiar with different languages and stuff. I had an elder sister. My elder sister did a translation studies at some point, and she changed to law, but she did translation. And so that was something that was really, and it was a good career, an appealing career. It was in a controlled environment in an office. Well, not going into interpreting, which was a different thing, but a controlled environment in an office. So it was something stable. If the love of my life probably was medicine, or medical school. And so, but that was completely unthinkable, going into an environment where you have infections all day long, and long shifts, and standing up, and you don't know when you eat, and
I just thought that, could I have done my nursing job? I don't think I could have.
But there are sickle cell patients that do that. I really admire them. But things are a little bit different, and depending on the country where you are, you can ask for like adjustments, which help. But I know a lot of people that, for example, then decide to go as a GP, or decide to find a consulting role rather than actual doing shifts in a hospital, because that is very demanding.
Yeah, of course, there are different pathways you could go.
Yeah.
All right. During university time, did you have any struggles with your sickle cell, unusual struggles, worse or other than in your childhood? When you have like a full-grown body, I can imagine that things change again when your hormones are all in levels and all this.
Ooh. That's an interesting point of view. I never thought of that way. I can say that I think that the most challenging period were the teenage years. That's when it rocks the boat for everyone, and it was difficult to control, with more crises and hospital admissions and everything. It's more difficult. The body is changing. You need to adapt, and you need to recognize, I think, we'll get there. So childhood was very difficult. I was ill at the time. I missed school a lot, but until my 15 years, so year 6 almost, I went to private schools. It was easier to explain the situation and to get some adjustments and some adaptations in private schools. And I never missed a year, but I missed classes quite a lot. So it was a combination. I was the 4th child. It was a combination. My mother was really strict of homeschooling and having support from for my siblings, and doing the tests when the time came. There was a very good communication doing the tests, and I would have better tests and not so good tests. When I was okay, I would go to school. So I think that probably in the beginning it was more difficult for teachers to trust that it would work, but eventually it worked. And so I never missed a year, but there were some periods, and winter was more difficult, where I would miss classes a lot, and I was doing it from home, and then my mother would be the link going to get the notes and get the notes from colleagues and get the tests and then deliver the tests and the assignments.
Oh, that is so much easier these days, right?
There you go. So it's quite different nowadays, and you can ask for, not everywhere, but in Europe, in quite a few countries, sickle cell is already recognized, not as a disability, although it should, but as a rare disease to start with, and that the kid really needs some adaptations and some adjustments. So that's part of it. So after, probably when I was 18, 19, so it coincided with New Year, it got more stable. And so with less crisis and everything, I would go to most of the classes already. And so sometimes I would fall ill as any other person can fall ill, and then I would recover. And it has to do with the relationship that you set with the teachers and your colleagues and everything, and you build like a closer circle where you can share the information and where you can get support from. Having said that, I think that one of the things that happens is that you learn to prepare in anticipation, because you never know when you will be okay on the day. And so if you are prepared, like, I can't do it today, or if I'm not feeling as good. I was 2 weeks ago in Prague for a conference. I was going to do a presentation on a poster. I had a painful crisis that came up at 3:00 in the morning.
Oh no!
I took my painful medication. I did go to the conference. I did the presentation, and then I get out. But I could only do that because, on one, medication was working, so I was in pain, but in a much lower level, and because I had prepared. And so because I had prepared, I had everything. I knew everything. It was just about delivering it. So not standing up, not dressed as I would like to because the weather was nice, but a lot warmer clothes and comfortable shoes and stuff like that, because that's what you need.
Yeah.
You learn to do that.
So you can say, like, after the stormy teenage years, you were settled a bit more in your situation. You knew your body, you knew how you react. And I think that makes a lot of sense. So When did you become a patient advocate and why
I was
and
thinking
how?
of, yeah, I was thinking about it yesterday. I think that maybe it was like I was 12 and my hematology consultant asked my mother to leave the room. She was a bit shocked. And he said she needs to learn to speak for herself, to know about her condition, and to be able to explain it and do everything without having her parents around or her siblings, because you never
Wow.
know. And that was, so I didn't have a transition as in some countries there is, of preparing a child to move from childcare to adult care, which is quite different because adult care is about self-management basically, and you need to be on top of it. You need to be on top of the appointments, the tests, and the medication, and everything. You need to be your own manager and
Yeah.
and do everything. And in childcare, there is a team, a multidisciplinary team that controls everything and that looks after you, and you have reminders and you have all of that. None as an adult. So I didn't have that preparation, but I think that that was essential because it's about, okay, instead of just coming into the room and just sitting down and your mother does all the conversation and I
Yeah.
talk to your mother, now it's about you. You are in the front seat and you need to, I want you to talk, I want you to listen. And okay, your mother is here, her input is important, her support is massive, as well as of the family, but it's about you. And I think that was the key. It's, and it is really about knowing as much as you can about the disease. You can never know everything, but knowing as much as you can. And at some point, there are times where I really wish I didn't know that much, because there are some darker avenues in it. And you
Yeah.
haven't been through it, but there are some darker avenues in it. But it prepares you in terms of the better informed you are, the better you can explain, you can recognize, and then it's about knowing your body and how you react to stuff. And that is really important. You know that if you have some specific behaviors, the possibility of triggering a crisis is higher.
Yeah.
And so you
Absolutely.
start having a more, probably a more defensive way of conducting yourself. And that helps. That helps. And so
Uh,
patient advocacy probably began there. Then maybe I was 32, 30, I don't know, in hospital admission. And I met, I started being followed in an oncology hospital because my hematology consultant moved to there. There you go, oncology, so the malignant side of hematology. So he moved there and I was followed there. And so I had contact with other patients. And other patients would talk to me about their associations, and they had this and they had that, and they had some support and maybe some financial support and social support and this and that. And don't you have anything? I don't know. But someone came around about a very new hemoglobinopathies association, because sickle cell is one of the hemoglobinopathies, along with thalassemias, and um, and talked about the association. And I said, well, I don't really care about that, because when I'm okay, I don't want to hear about the disease. That's
yeah. Yeah.
usually the thing. But then when I came out, I contacted them and I asked, okay, so what do we have in terms of financial and social support and so on? It started like that, but it was just the beginning, because
Yeah.
then I was involved in a lot in events, in translation, in communication, in a lot of things. And that started in Portugal. And then when I moved to the UK and I looked for a supporting network outside of London, where the majority of patients are and where the majority of support is, I met this girl, which is part of the European reference network for her rare hematological condition, Zero Blood Net. And she told me, well, I'm a patient advocate. I think you would be great. Do you want to come around for a meeting and know them and so on? And that's how it started. And nowadays I'm also part of the European Sickle Cell Federation. So an umbrella organization for patient organizations at the European level. I sit in the European Hematology Association Patient Advocacy Committee. So again, EHA is a massive organization in terms of hematology, a reference one for clinicians, but they are also very keen on having the patient voice in there present. And I'm in the UK. I'm part of some patient voice groups, the patient community in the hospital where I go to. So, yeah.
Sounds like a very busy woman. Just to make this clear, this is all volunteer-based, isn't it?
All volunteer-based.
Being a patient, I think that many people don't understand that being a patient advocate is not a job, even though it feels like a job, but it's mostly nothing that you get paid for. You do that out of passion.
There are some patients that have rules about patient engagement, or maybe other roles in their organizations, usually in the malignant conditions where there is more money, and because they do it on a full-time basis. And so they do patient advocacy as a whole for the organization, for the condition, and not for sickle cell. I don't think I know anyone in sickle cell that is lucky enough. I'm not sure if lucky is the right word, but if they have like that kind of full-time role,
lucky in an unlucky role too. Interesting.
And so that's how I got into the medical translation. And the more I sometimes and as a trying to define myself, for example, in LinkedIn and trying to find an identity, it's very difficult to distinguish the patient advocate from the medical translator and linguistic validation consultant, because in a way they contribute to each other. So it's being a patient and being a patient advocate. I really know patients. I really understand patients. I really know their needs, how they think, what doesn't work, what's the importance of language barriers, because everything is in English. And the reality of sickle cell is that is a huge community, but the majority of the sickle cell patients are probably in sub-Saharan Africa, or are people with origins from different parts of the world, but with low literacy levels, the majority. And they don't, well, there is a big chunk from the English-speaking African countries, that's a fact. But for example, research, most of it's located in the US, in Europe, in Asia. Everything goes in English, right? And then there's the bits that we all know about with the medical translation and the linguistic validation. And it needs to be clear language, plain language, accessible language. Research needs to reflect more endpoints than the ones that they go for, which is usually the survival rates and things like that, and focus more on quality of life, because yes, patients live longer, but they want better quality of life while they live. And what they give priority to many times is not the same thing that the clinicians give priority to. So it needs to be aligned with the patient preference and everything. And that is the thing that being a patient has an advantage, and being a patient advocate has an advantage. And the other side of patient advocacy as well is the policy. And that's, for me, the most difficult thing, because it's huge dossiers at the EU level. And it's areas where it's difficult to penetrate, because it is a lot that you need to know. But that's the thing. The more I know from the medical and translation side, it feeds into the patient advocate and vice versa. So it really helps. And even though, because I'm just going into the medical translation and linguistic advocacy, so I don't have a lot of work, it has been difficult to find an in-house job. That would be my goal, but it hasn't been possible. As an independent professional, I apply, but applying is one thing and getting the jobs is a different thing. And European Portuguese, which is my native language, is a lower demand language, so
Yeah.
a lot less. But I get a lot of experience from being a patient advocate because I receive patient surveys, oh my God, so many times. The thing is now we're translating this with AI and we're going to shipping. And I say, okay, please let me have a look.
Yeah.
Or sometimes there is something more and more. The patient advocate is going into the embedding into the research design, not up to the very beginning where we would like to sit to be able to shape research, but for example, to contribute with input for the this is the study protocol. Can you have a look? Would it be any different? What input can you give? And
Yeah.
this is the leaflet that we're going to give to the patient when they go to the study site and they're going to do this and that. What would needs to be different? And there is so much that we can do in that sense. So things are getting intertwined.
Yeah, but this sounds like your life's mission somehow, something, everything led together, your passion for language, your background. And for me, it sounds totally interesting to be on the side of like validating leaflets and all this. I think that would be so interesting to be seeing this material and commenting it and maybe being a part of making it even better for the then patients in the hospitals or the sites where they are. So I think this, at least for me, this sounds like something valuable you're doing there. And
Fingers crossed. Yeah.
yeah,
Also contributing to leaflets that I don't know, I help with the Portuguese Association with the social media, meaning doing posts that are informative on things
yeah,
that we do, on aspects like, for example, 2 weeks ago it was Blood Donors Day. Blood is a big thing for us,
yeah. I
and
get that. Yeah,
many patients live on blood transfusions, regular blood transfusions every 6 weeks, every 8 weeks they receive. So they need blood, and they need blood that matches their genotype because they have specific characteristics, and most of the blood donors are Caucasian. And the what we need, or what the patient needs, if they're African, Black African, they need from Black African people. If they're Asian, from Asian people. Otherwise, they can
oh,
develop. I think it's
interesting.
antigenes. That means that it creates some resistance
Yeah,
to blood when you receive it, and then it doesn't work anymore. So those are important aspects. There is an education factor about it, and about letting the world know what sickle cell is, what the needs are, what the patient needs are, but also the community, because the community also needs to learn. And
yeah.
culturally, they don't like to talk about it. It's considered like a weakness in some families. It's like almost a sin if you have a child with sickle cell, because it's like it's tarnished. There
Oh,
are a
wow.
lot of factors into it that we need to break that, and we need to move into, because we need people to come up and to speak up, and the more they speak up, hopefully they will have more access to it. The access is a difficult thing as well, because it's they don't even in many countries, in many African countries, they don't even have access to medication or to proper diagnosis,
Yeah,
or to mm, clinical trials usually don't go there. There
yeah,
are exceptions, but there are. And even in Europe, and I was in the EHA, I attended virtually. I couldn't go in person because I had just had a crisis, but I attended virtually. And there were some presentations in the European Hematology Association Congress a few days ago about exactly the difference of access to clinical trials and research, even in Europe, between Northern Europe or Central Europe and Southern Europe.
yeah.
It's quite different. And men and women. And
Interesting. Yeah.
there are differences. So we need to, and that is only in Europe. if you go wider into the whole world, it's insane. So we need to improve that.
Yeah, I mean, we always need some new goals, right? I have, for now, one more question. You said when you travel, you pack all your medication. I, as a nurse, am really interested. What is in your backpack then? What kind of medications do you have to take on a daily basis?
Okay. So
if that isn't too much,
it's probably about 9 medications right now. It's quite a lot. And then you need to be aware of polymedication. And that's an area that I'm really interested on because I don't think we know enough about that. And polymedication is considered when you're on 5 or more on a regular basis. Okay. So, but I take from childhood folic acid, and the dosage is completely different from what pregnant women take, because all pregnant women, or most of the pregnant women, should take it. But the dose is completely different because we have a deficiency there. So folic acid from the beginning, from whenever I remember, I had folic acid. I don't have penicillin on a regular basis anymore because there is no scientific evidence. There are 2 different trends of having it as an adult or not, because then you develop a resistance to antibiotics, and when you need it, it doesn't work so well. So the opinion of my hematology consultants was always, let your organism do its own work, and when you need the antibiotics, we'll give it to you. And so I don't do it anymore. But there are people who do it, and it's part of the plan their whole life. And so I have been doing for 30 years now a medication which is called hydroxyurea, which is oncology medication, but has proven to improve the values in hemoglobinopathies patients. So that as well. I am on thyroid medication because I removed half of my thyroid a few years ago. I am on blood pressure medication because I have high blood pressure, and so it needs to come down because otherwise it's a massive effort for the heart.
Blood thinners.
Blood thinners. There you go. Vitamins, because I live in the UK and I'm not as exposed to sun as I was in Portugal. So vitamin D. When I go to Portugal, for example, in September, because I go to the beach and everything, the doctor says, don't take it when you're there because you will get the sun that you need, the sun exposure. But once I go back to the UK, there you go. I have, something for restless legs, because I have been restless legs for quite a few years, for a few years. So for restless legs, and it also helps with sleeping better. It doesn't mean that I sleep well, but it also helps with sleeping better, which with menopause has been difficult. Menopause brought a lot of more difficult things to it in terms of anxiety, of sleeping not that well, of hormonal imbalance that you were talking about that. So also hormonal patches. I have hormonal patches. And maybe that's it. I think it's 9.
I think that's enough.
But that's enough.
That's
so I
enough.
need, and then I have the ones which is the pain medication, which is specific for crisis. I don't take it on a regular basis, but I need to take it with me in case I need it. And it starts with paracetamol, for example, the first level, and then a combination of paracetamol and ibuprofen. And then second level, it involves opioids at some
already. Okay.
And on a third level, it goes into morphine because, as I said, the pain can be really unbearable. But once it reaches morphine, it's time to go to hospital.
Yeah, I get that.
So, but you need to have something to start lowering down, because if it is really strong, then it's very difficult to get a hold of the crisis from the beginning, because the pain overtakes everything, and then it's a lot more difficult.
Yeah. Well, we would have at least I don't know how it is in Sweden, but we would have between the step 1 and 2, we would have Novaminsulfol or Novalgin. I don't know what's the English equivalent, but this is something in between. It's stronger than ibuprofen, but it's not an opioid yet. So we give this for example, if you have like a kidney stone or something, and then you have like real cramps, and then this actually helps quite well. So I'm surprised you have only that big gap between ibu and
but well, the
opioids.
protocols are different because, for example, the pain medication in Portugal involves medication which is not available in the UK.
Yeah.
And I think that in the UK they have an approach which is maybe stronger pain medication at a lower level.
Yeah.
But I need to follow the medication.
Every country does that differently, right? I mean,
Yeah.
the main important thing is that you get over the crisis somehow, right? Well, we are nearing the end. I would like to open the mic for Angelo. I'm sure he has a question or a comment or anything worse.
Well, yes, I actually have two questions, Miriam. The first one, while you were speaking, I was thinking of having an invisible disease.
Mhm.
So how do you cope, socially speaking, how do you cope with the fact that you have an invisible disease, nobody sees it, nobody knows about it? So how is your experience with that in terms of the sickle cell disease?
I think it will vary from person to person. The way it has shaped me is that maybe you could say that I have trust issues. And that's what I was saying about the energy saving mode. So I save my energy for what is really important. Although I am a social person, but I think that there is a close circle where I'm my own self and people know that I have stages where I have lower energy and I can't participate. And if I say someone, oh, for example, and this was patients, everyone was patients the other day. I was in Padova for a conference or for a capacity building a couple of months ago. Padova is quite close to Venice, right? It's 40 kilometers away from Venice. So the girls decided, okay, let's go to Venice on a Saturday night evening. And I said, I'm not going. And they said, but why? And I said, because I am too tired and I have to fly tomorrow. I'm flying alone, so I need to rest. I would love to go to Venice, but it's like choosing. You go to Venice and then the other day what happens? Or you don't go to Venice. I've been to Venice many years ago, but I have been to Venice. Or you don't go out with the girls, which is a big no-no for socialization. But you take a defensive approach and you're more comfortable traveling the day after, because traveling alone is a very big feat because you need to have your energy for whatever comes around, and there are many unpredictable things that can happen. So that's one of the things, and it can happen with anything, going to a disco, to a bar, to the beach, to anything. So you're not very social, but usually I really don't care about it. And I don't even get enough. I just say, I can't go. If people understand it, they understand it. If they don't understand it, tough. Most of the times, I don't go into the length of explaining why. I explain why if I have some closer relationship with people, if there is some interest in my person, in other areas. Otherwise, I'm the maybe not so nice girl and a bit grumpy, but that's okay. That's fine. And that shapes you. That shapes you.
I totally get it. Yes. Thank you. The second question, but before the second question, I would like to thank you very much for this talk,
Thank you.
for opening up so much information about a disease that actually I hadn't heard before. I heard it from you.
But it is very common in Brazil.
Yes, yes, I was looking into that, and I was even seeing the name of the disease. I hadn't come across the name of the disease, you know?
Okay. So in Portuguese, there are 3 different designations for the disease. We have one which comes from the French side, which is drepanocytosis, probably the Latin. Okay.
Uh-huh.
And that's very used in the French-speaking countries and in also the Portuguese-speaking countries. And then in Brazil, they went with the direct corresponding to sickle anemia, which is anemia falciforme or even doença falciforme. Okay, that's the thing.
Mhm.
Yeah.
Yes. Perfect. So thank you so much. I saw your poster presentation, by the way, and just for you to know that from the outside, we couldn't say anything was happening actually to you. You know, although you were sitting down,
Yeah.
but it could be like a pain in your food or something like that. So
Yeah.
so
Thank you.
once again,
Well done.
it's great.
I really prepared for that because there is a time limit for those presentations. And usually I talk a lot. I get very excited about the topic and I talk about. So I really had to time myself, and it took longer because I was speaking slowly. But that's the only thing. I am really aware of that. But that's where the preparation comes in. And many people, other people in the sickle cell community, because it's like maybe 90% or 95%, either patients or family or someone that knows someone that has sickle cell. But there are people who are, for example, healthcare professionals that get really passionate about sickle cell and want to help as well, but they see what it's like, but they don't know what it's like really. And we have two trends of people who wing it in the presentations and who are more into networking and have a different approach. But most of the patients are like, I better prepare beforehand, just in case on the day I'm not able to do it.
Right.
That's a very good conversation. It starts from little, from school. Yeah.
Your second question, Angelo.
Oh, sorry.
No worries, no worries.
It was about actually your patient journey in terms of the healthcare system and the healthcare professionals that you've encountered through your life. I mean, how do you feel about it? Just for you to know why I'm asking that. I feel that for many diseases, chronic diseases like ours, we tend to receive some sort of different treatment from diseases that are usually more in vogue. I don't think that would be the right term, but diseases that are more seen
On the
socially
radar.
somehow. Yes, exactly. And I feel that sometimes we do not get the proper treatment or the proper a proper way to deal with us from those who take care of us, like from the healthcare system, from doctors and nurses sometimes.
Do
So
you mean you are overlooked somehow?
yes, yes. So what is your experience there?
Okay, I could go on this for a whole hour, but I'll try. I'll try to be okay. So
try to keep it in
Another
3 minutes,
MedTalk.
maybe.
not sure about 3 minutes, but let's give it a go. Okay, so I remember from watching your episode yesterday that one of the things that you said, which is really important, is that both Portugal and the UK have a government subsidized national healthcare system. So it means that it's universal, and it's free. So based on the taxes that you pay and everything, it doesn't go like insurance based as it's in the US and in many other countries. That helps a lot because you have very good professionals everywhere. You also have bad professionals, but you have very good, and you have very good care as well. And my whole journey was based on the national healthcare system in both countries. Having said that, as a child, it was also necessary quite often, as there was little knowledge, to recur to private healthcare for specific consultants or for to get around the waiting lists, because that's one of the problems with the national healthcare system, or to specific exams or things like that. So I was fortunate enough that my family could afford that, and that we could, for example, the same way that nowadays you try to have care nationwide, let's say it. I always lived in the capital, and that helps a lot because all the resources are in the capital city. But there were some other reference centers which were not in the capital. They were more in the north part of the country, or in the or in the center. So it's still today for hemoglobinopathies, Coimbra is in the center, and they are the national reference center for hemoglobinopathies. And whenever it was needed, my parents would take me there. My mother would stay with me there for, I don't know, a week or 2 weeks or whenever it was necessary. And it also takes some money to be able to do that, right? So that is one thing. The other thing is that despite the little knowledge, one of the other things is that, so my blood had to travel to, if I remember correctly, South Africa, Canada, and the UK when I was little for the diagnosis confirmation. And my parents started, because we had doctors in the family, started correspondence with leading hematology consultants in these countries, and also in Israel for a while, about the condition, about medication, the treatments, what was being done, because there was very little knowledge. And so I think that the languages and the advocacy also came from there, because my sister would help initially. And then as I knew more about English and other languages, I would also help with that. And it really builds the knowledge and everything. So, and then you start looking for whatever is known abroad that you can apply or that you can ask about it. Another aspect, research. So in some countries like the UK or in France, or I think that it is available already in Portugal, but there is no culture for it, a portal where you have all the clinical trials. There is a portal for the EU. There is a portal worldwide where you have all the clinical trials. But usually you have access to research and clinical trials because your consultant says, I know of this, and this would be a good option for you. You're not an inquisitive patient going for, let me check about clinical trials. Maybe there is a very small percentage of patients who do that. So you do rely on the structures that you know, and then the availability of clinical trials, as I was saying a while ago, it's much smaller depending on where you live, in the part of the globe where you are. So less clinical trials are available in Portugal. I'm in the UK, and I can see the difference between the UK and Portugal. And it is really even between Spain and Portugal, it's like massive. So you don't know about it. And then twofold, you don't know about it. And then when they are, many patients don't trust the system. They have a difficult experience with the healthcare system because you go there and most of the healthcare professionals don't know about sickle cell. And I think that less in Portugal, more in the UK, they don't listen to you. And if you say that I know myself, I know what I have, and even I have documentation here, that's one of the things that I always recommend, is carry a letter from your consultant with your diagnosis and your baseline levels and your emergency care plan with you. because it has a name, a phone number, a stamp of the hospital. So it validates that you have a diagnosis there. And it has your baseline values, which is really important. And every care plan is tailored for you because every patient is different. So mine is different from the next person, right? So carry that with you. But then the healthcare professionals don't react really to the best of their ability when you present there and you are taken as an arrogant patient that, like, oh, she thinks she knows more than I do and I have a degree. It's not about that. It's just because I know how very little knowledge there is, and because it's different for me. There is medication that doesn't work for me, and there is medication that works for me. And the level of medication that you need to apply, especially when you go into opioids and morphine and stuff, it's different. And so I'm telling you that I know that this is how I work, and I know that this is how it is. And it is so difficult. It's such energy draining trying to explain that. And the more you're trying to explain, is like you have a wall in front of you. And most of them don't listen. So please listen to your patients. They do actually know what they're talking about. And it does help a lot. So it's that difficult relationship, right? And research also needs the patients there to know about this stuff. We want research that is relevant and that goes for what we need alongside with what clinicians know about how it goes.
So to summarize this, you did have a lot of support, but then when you come to the actual communication with the actual HCP, you do feel like this wall, as you described it.
It's epic. And you have your team, you build a very good and trust relationship with your team, very strong, but your team very rarely is available when you have a crisis. Either because you're not in your local hospital, or because crises very often, for some weird reason, happen later during the day or on weekends, and the team is not there. So it's like you go, it's like, okay, your file is in the system, but it's like you're completely new to everyone that looks at you, and they don't really trust. You look so well, and myself, because sickle cell disease is considered a black people disease, because the majority of the patients are from African origin, but not all the patients are African origin. I also have African origin, but I also have, I'm basically white. I also have some Jewish heritage there that influences, and they look at me and they say, first reaction, you don't have sickle cell.
Wow. It's not that you live with it for like 57 years. It's like, no. Wow.
So,
Well, thank you for this explanation. I think, Angela, did you want to react to that? It was your question after all.
No, it's so nice to I mean, it's not nice to hear that, but it's nice that we
but it's important to talk about this
and each other.
And thank you for the questions, and I hope I have answered, because there is so much. I know that we have little time, and there is so much that needs to be packed into that. But
absolutely,
whenever you need, ask, and I'll say whatever.
Well, Miriam,
and I have to say something here too.
Yes,
it's that I love listening to Miriam, Catherine. Yes, because her voice has something there that calms me down so much.
Oh,
so God. It's therapeutic to me. Okay.
Well, you can keep listening to it when it's uploaded, and you can just keep it on repeat. It's your bad night story. That's wonderful. Oh, you're so sweet, Angela. Well, I want to say a big thank you to Miriam to going with us down the memory lane, as you said yesterday, and it was extremely interesting also for me. I haven't had a lot of knowledge about sickle disease, and now I have a much clearer picture. And I think the last sentence you said is please listen to your patients. This is something that I keep saying since I can think to my doctor colleagues. So please, doctors, if you listen here, listen to the patients, because they live with the disease and they do know a lot about it. Unless they come from ChatGPT, freshly Googled their fresh symptoms.
Well, not every patient knows about it, but I think there is a lot, and some of the role of patient advocacy is also teaching the community and helping the patients know more about it.
Yeah.
But yes, if a patient wants to tell you and show you something, please. We're not arrogant. We are just desperate, crunched between the pain and the fatigue and the lack of energy, and trying to pass a message that, okay, please some attention here because this will be useful.
What a perfect finish of my MedTalk here, because this is what MedTalks is about. We want to bring people together and the different opinions and experiences. So once again, thank you so much for being here with me, and we just keep staying in touch. And if you want to talk to Miriam more, Angelo, just get her number.
Oh, thank you. Yes, I'm on LinkedIn and a few other places, and you will see me around. So if you have any questions, please. And I would like to thank you, Catherine, because it all started with the linguistic validation and then the how to speak cancer. And I think that one very important cross reference or whatever with the cancer is the supportive care, which is really important. And in hematology, oncology, and malignant conditions always lead the way, the funding, the resources, but we inherit and benefit a lot from it as well. So we need more for sickle cell, but it needs to be a dialogue. So thank you very much.
Maybe we have another dialogue about that too.
Okay.
For now, I want to thank you and say goodbye and have a nice rest of your day, you too.
Thank you very much. Have a nice day. Bye. Go back to bed, Angelo. And I hope that the weather